Next is V8. It's perforated diverticulitis. A 74-year-old male with a known history of diverticular disease presents with a one-day history of recurrent abdominal pain associated with fever and tachycardia. Blood tests show red inflammatory markers. A CT scan of the abdomen shows a thickened and inflamed sigmoid colon with a free fluid and air. So it's most likely Hinchi 4 or Hinchi 3. How would you manage this patient surgically? Assuming the patient is fit for surgery, so I would do explorative laparotomy plus minus Hartmann's procedure. So what are the steps in performing the Hartmann's procedure? So supine position, lower midline incision, mobilization of the left colon proximally from the descending colon, sigmoid colon junction and distally below the pathology. Identify the left ureter, division of the mesenteric vessel, inferior mesenteric artery and sigmoid branches, transection of the sigmoid colon, closure of the rectal stump, peritoneal lavage, insertion of the drain, closure of the abdomen and fashioning of an ankylostomy. Where is the left ureter usually located? What is the significance in this patient? The left ureter is a straight tube which originates from the left kidney, runs in the retroperitoneal space along the middle part of the sauce and crosses the gonadal vessels and colonic vessels at the base of the sigmoid mesocolon. It passes through the intersigmoid mesenteric recess. It lies anterior to the bifurcation of the common iliac artery. In the pelvis, the ureter runs on the left lateral wall of the pelvis and lies anterior to the internal iliac artery before it turns forward and medially to enter the bladder. In a diseased colon, for example inflammatory or malignancy or previous surgery, the left ureter may be in a more medial position and be closely adherent to the posterior peritoneum. And the colonic pathology with increased risk of ureteric injury. Where would you place the ankylostomy? The pre-ureter stoma sighting is encouraged. The ankylostomy is usually placed over the left rectus abdominis muscle to reduce the risk of peristomal hernias, about 2 inches from the umbilicus laterally, to allow the placement of stomal appliances. The patient has a stormy postoperative course on intensive care. On the 4th postoperative day, you are asked to review the patient. His colostomy has turned necrotic. What would you do? The extent of necrosis needs to be established with the inspection of the colonic mucosa through a transilluminated glass tube or the endoscope. If the necrosis lies above the fascia, it may be treated conservatively and the stoma revised at an interval period. Necrosis of the stoma below the fascia runs the risk of retraction and disarticulation with ensuing intra-abdominal sepsis. Immediate revision surgery is usually warranted. How would you revise the stoma? At radial laparotomy, I will dismantle the stoma and mobilize the left colon further up to the splenic flexure. The splenic flexure is mobilized from below upward in the retroperitoneal fashion from the line of Todd, and from above from the middle aspect in the left aspect of the transverse colon by dissecting the greater omentum away. It is crucial to ensure that the stoma is healthy with colon not under tension, preferably with some redundancy. Thank you.